There we go. Hello, everyone. My name is Rebecca Ford, and I'm a clinical research coordinator with Norton Infectious Disease Institute. So I have worked in refugee healthcare for approximately 10 years, a little over 10 years. Prior to coming on board at Norton, I got started working in refugee health surveillance in Kentucky. And then I began working with refugees directly in a vaccine clinic and health screening clinic. And then I went on to work at the state level administration for refugee healthcare. So that's my topic today that I'm going to go over. So some of the objectives that we're going to go over today, you're going to learn a little bit about refugee resettlement in the United States, refugee healthcare in Kentucky when refugees first arrive, and then we're going to go over some best practices working with refugees in a healthcare setting. So I wanted to start out with some definitions because oftentimes words are thrown around working with immigration, and these words, although they can have different meanings, they do have legal ramifications for individuals. So that's why I want to start out with these. A refugee is an individual who has left his or her own country and is unable or unwilling to return due to fear of persecution for a number of different reasons. So technically, to be a refugee, someone does have to cross an international border. And then in the United States, refugee is a legal immigration status. Now I'm going to go over some more terms that we use in refugee resettlement, and all of these immigration statuses that I've listed here, they are eligible for refugee services and benefits here in the U.S. We call them ORR, eligible Office of Refugee Resettlement, and that's a department within the Health and Human Services that funds many post-resettlement programs. So a Cuban Haitian entrant is an individual from Cuba or Haiti that has arrived in the U.S. and they're given special status due to politics in their own countries and granted by the Cuban Adjustment Act. Louisville serves as a hub for Cuban refugees. We're a very large resettlement site for Cuban refugees. Most states do not have a program like this. I believe Florida has a large program and Nevada as well. An asylee is an individual who has somehow come to the United States on a tourist visa, student visa, or perhaps crossing of the southern border, and they make a claim of persecution and inability to return while they are here in the United States. The asylum process in the U.S. can take many, many years, but once someone is granted that status, they become an asylee and they are eligible for refugee services. They are not eligible for services while they are waiting in the asylum process. Then we have an SIV. Those are special immigrant visas. Those are people from Iraq or Afghanistan who worked for the U.S. government during the ongoing conflicts there. Then Ukrainian humanitarian parolee, that's a new status that we're seeing referring to individuals who need resettlement based on the conflict in Ukraine. And then finally, we have, while not an official immigration status, secondary migrants, we use that term a lot, and that is an individual who has a refugee who has initially been resettled in another state, but then chooses to move to Kentucky or any other state. Refugees can move about the United States as they please. They don't have to stay in the original state that they are resettled. They can move around just like anyone else. So a little bit about the resettlement process overseas. Once an individual crosses an international border, they must register with the UNHCR, the United Nations High Commissioner for Refugees, and they are tasked with leading international action on refugees worldwide. So we call this country that they go to register with the UNHCR, we call that their second country, even though that might not necessarily be the second country that they cross to, just to make things easier. Their second country is where they register, and then they can live, a lot of times people live in refugee camps, and they can live in there for a very, very long time. The UNHCR has 3 solutions for refugees. The first of which is that they can return home, assuming that the conflict has died down and things are safe. People can return home. The second option is integration into that second country where they resettled. And then the third option is resettlement into a third country, such as the United States. Less than 1% of all people who have fled their homes are ever resettled in a third country. Canada is accepts the largest number of refugees worldwide, then the US, Australia, and then a few other countries participate in this program. This slide shows where refugees are originating from worldwide, and you can see Syria, Ukraine, Afghanistan, those are the top countries that are where refugees are from. And then the second graph shows where refugees are living by host country, or that second country that I talked about, with the largest being Turkey. So once it is determined that a refugee can neither return home or be integrated into the second country, the process for resettlement for them might begin. This process is very long and takes many, many years. There are a number of interviews, background checks, various screenings by different organizations. It's often said that refugees are the most thoroughly vetted individuals who immigrate into the United States. So this image is just a snapshot of some of the processes that and all the different organizations and approvals that a person or family must go through before they're approved for resettlement into the United States. A lot of different organizations are involved in refugee resettlement. I already talked about the Office of Refugee Resettlement, and they fund a lot of post-resettlement services. Then the State Department is involved with the Bureau of Population, Refugees, and Migration, PRM. They decide which people or different groups are eligible for resettlement. They fund overseas refugee processing, transportation, cultural orientation, and they fund the first 30 days of services for a refugee when they arrive in the United States. Department of Homeland Security is involved, USCIS, and all the security and background checks and whatnot. They are also involved in the permanent residency application for individuals once they arrive here in the United States. So if a person makes it through all of those background checks and screenings and interviews and whatnot, and they're chosen for resettlement, anyone who resettles in the United States must receive an overseas medical screening. They usually receive that about 5 or 6 months before departing for the United States. The screening includes a physical exam, labs. They're really looking for any infectious diseases that could spread. They want to get those addressed before a person is supposed to depart, so they're healthy and ready to go. Individuals are screened for tuberculosis, and they receive immunizations, really depending on what's available in that country that they are going through the processes in. So they'll usually receive another screening about 3 weeks before departure, and then again 24 to 48 hours right before they leave. The U.S. has a long history of welcoming refugees. The president consults with Congress and sets a ceiling for refugee admissions each year. And you can see in these numbers, politics really began to play a part in the ceiling that was set for refugee arrivals starting in 2018. And then in 2021, we saw the lowest number of the lowest ceiling that has ever been recorded for refugee admissions into the United States. But then that was changed after the election to a little over 62,000. Even though the ceiling now is back up to 125,000, so far this year, we've only welcomed a little over 30,000 arrivals. It really takes time to build the program back up after a lot of people were laid off. In some countries, the program's closed. So they're still working on building capacity back up. Every state that resettles refugees has a state refugee coordinator's office. In most states, that office is in the state government. But in Kentucky and a number of other states, the state has opted out of refugee resettlement and a private nonprofit has taken over. In Kentucky, this happened many years ago. It had nothing to do with all the politics and everything that went on. Catholic Charities has run this program for a very long time. So that office within Catholic Charities is called the Kentucky Office for Refugees. They oversee the resettlement process in Kentucky, and they act as a pass-through entity for federal funds associated with the program. There are 4 resettlement agencies in Kentucky with 7 different offices. In Louisville, there's Kentucky Refugee Ministries, Migration Refugee Services, and the brand new resettlement agency, International Rescue Committee. Kentucky Refugee Ministries has a sub-office in Lexington and Covington, and the International Center is the resettlement agency that serves Bowling Green and Owensboro. Resettlement agencies provide on-the-ground services for refugees when they first arrive. They provide immediate resettlement needs and then ongoing casework. The caseworkers find an apartment for families before they arrive and set it up. They pick them up from the airport, provide initial transportation. They offer ESL classes. They register kids for school, help adults find jobs. They sign up folks for benefits like Medicaid and food stamps if they're eligible. And then they help follow up with healthcare needs. The most intense case management is offered for 30 to 90 days, but refugees can offer services, can access services for up to 5 years after their arrival. But that's the technical definition, but really refugee resettlement agencies will always help anyone who comes and asks for help, even if it means just referring them to another organization that for benefits for which they're eligible. But they're always a good place to go for help with refugees. So this table just gives you an idea of where refugees in Kentucky are coming from. This first table represents numbers for this fiscal year, which starts October 22, and then the numbers go through March of this year. And in the second table, you can see that Kentucky is the 4th largest resettlement state in the US, behind Texas, New York, and California, which is really interesting because Kentucky is kind of a smaller state compared to these much larger states. And then just as a side note, this number for the state rankings do not include Cubans. It is only including the strict definition of refugee that we talked about in the beginning. This is a table that shows you the most common languages found in Louisville over the past 5 years. So all refugees who arrive in the US are eligible to receive a refugee health screening. The screening is meant to happen within the first 90 days of arrival. Guidance for this screening is provided by the Center for Disease Control. The purpose of the 2-visit comprehensive exam is to ensure follow-up from some of those overseas conditions that were identified, to identify anyone with a communicable disease, to find any health conditions that might impact their ability to successfully resettle in the US. And then it's also meant to introduce and educate people into the U.S. healthcare system, which can be a confusing system. The Kentucky Office for Refugees contracts with specific clinics to provide this exam. So only certain clinics can do it. And that way they know that it's done completely with culturally competent providers who always use interpreters and know how to work well with them. And just as a side note, refugees are eligible for Medicaid when they come to Kentucky. They are eligible for as long as they are income eligible. There's no time limit or time maximum. They're eligible just as long as anyone else in Kentucky would be eligible for that. Working with refugees, it can be a very rewarding experience, but it does come with some challenges. Appointments can take longer because you have to use an interpreter. I often heard providers mention that refugees can come late to their appointments, or they don't come at all. Or, that refugees' understanding and expectation of the U.S. healthcare system can really vary very widely. So, in order to, if you are working with refugees, to improve that experience, the first and most important thing you can do when working with refugees is to use a qualified medical interpreter. Now, to many of us, that might be obvious that we need to do it. It's the law. At Norton Healthcare here, of course, it's the policy. Any other hospital system, it's going to be the policy. But there can be a lot of nuance when using an interpreter. For example, if the person agrees with everything you say and doesn't ask any questions, says okay to everything, it's likely that they don't understand you, even if you are using an interpreter. I recently had this happen to me. Even though I've worked with refugees for years, I worked with a participant recently in one of our research studies, and I knew that person spoke Somali. It said it in her chart, and then I asked her when she got to the appointment, what language did she want me to call, and she confirmed that it was Somali that she needed. But once we started this visit for this research study, I could tell something was wrong because she was saying okay to everything, just nodding along. She wasn't asking any questions. But I wasn't really sure what was wrong because I had the right language, so I thought. But it wasn't until I got into started asking her some questions that the interpreter on the phone let me know that it was actually the wrong language and they couldn't understand each other. And that while they both spoke Somali, they spoke different dialects of the language. So then I had to, call the language line back, get the right interpreter, start all over. We got along much better after that. But if I hadn't asked her any questions, I wouldn't have known what the problem was. And interestingly enough, the participant's English-speaking bilingual daughter was at the appointment too, and she didn't say anything either to me. She didn't say anything was wrong, which just goes to show another point in working with refugees is that in some cultures, it is just not appropriate to speak up against someone that they view as in a position of authority or a doctor. Like, even though I'm not a doctor, they sort of viewed me in that role, and they weren't going to say anything was wrong. So using an interpreter isn't always an intuitive process. It's something that could use with some training. There are a lot of videos online. I could give a whole day's worth of presentations on how to use it, but an important point is to speak directly to the patient as if the interpreter is not there, because the interpreter is going to say exactly what you say. So you wouldn't say like, interpreter, ask her what her date of birth is. You would just say, what is your date of birth? Also, an interpreter needs to be used for the whole interaction in a medical setting. It's difficult to go through a registration or sign-in process without an interpreter. A lot of times people might think, oh, well, we'll just call the interpreter when they get back there with the doctor, and we'll figure out everything else using IDs and stuff. But it really is important to use an interpreter through the whole process, especially if it's their first time ever coming to that clinic. It is helpful when working with refugees to have an understanding of how culture can impact behavior. As I mentioned before, some cultures are more direct or indirect. Indirect communication style, which is tend to be the way Americans interact. Is communication and conversation is very frank, blunt, and honest. Indirect communication is often more subtle and diplomatic and talking around the issue. It can be hard to get used to that. Also, in the US, we tend to be very task-oriented, and meaning that success is defined by accomplishing a task. In other cultures, the relationship is much more important. Even if the task is completed, if everyone's angry and upset with each other, then that was not successful. Success is in building relationships. The US culture tends to be more individualistic and focused on self-determination, the pursuit of self-interest, and collectivist cultures tend to put more importance on the group and getting collective agreement. And then cultures can also differ in time orientation. I hear about this one a lot when working with refugees. In the US, we tend to be very focused on time. Time is a limited resource. High value is placed on schedules and deadlines, and it is considered rude to make another person wait. Now, in other cultures, time is a little more fluid. It's more relaxed. Waiting and last minute changes to schedules are just not even an issue. And this one does tend to cause the most frustration because Americans really do see being late as rude, or they see people being ungrateful for being late to their doctor's appointment. And other cultures just might not see it that way. And so it's something that has to be learned. Refugees often have to learn, hey, if you're late, if you're more than 15 minutes late to your doctor's appointment, they're not going to see you. And usually through trial and error, they'll have to learn to get on time. It just takes a while to learn. And then some other barriers working with refugees is that even though, as I mentioned, refugees are eligible for Medicaid when they first arrive, keeping that Medicaid can be difficult because you often have to recertify, and those letters tend to come in English, and the website is in English, and it's hard to figure out what's going on. And then if the person becomes ineligible for Medicaid, say they get a job and they're working and their income is too high for Medicaid, then just trying to understand employer-based insurance or the marketplace insurance is really difficult. It's really difficult for an American-born English speaker to understand their employer-based health insurance, but really, really difficult for those who are new to the system. Transportation is a big problem for refugees who are generally relying on public transportation, especially when they first arrive. Again, interpreters, making sure there's always an interpreter, which we already talked about, but we need interpreters in more places than just the medical office, the bus system, dental offices, pharmacies, everywhere needs to be using interpreters if you really want someone to understand what you're saying. And then there's just a lack of dental and mental health providers who accept Medicaid. And then refugees generally are not used to that talk therapy model of mental health care that is commonly used in the US. So that is a very broad overview of refugee resettlement overseas in the US and in Kentucky. But if anyone has any questions, feel free to let me know. I think I saw some in the chat box. Yes. Let's see. So why is Louisville a Cuban hub? I guess there's no particular reason. It's just a long time ago when the resettlement agencies just started small programs for Cubans. They were approved to start small programs for Cubans, and once one family comes and then they have friends and relatives who want to join them, it's always easier to resettle in a place where you have friends and family there already. So they just started coming. More folks started to come and join their families. And then Louisville became known as a place that has caseworkers who speak Spanish, who have a lot of services for folks who speak Spanish. let's see, is an asylee ever considered an illegal alien? Asylee, so like I said, asylee is a legal immigration status. And that's after they're granted asylum. While someone is in the asylum process, that is also a legal, documented, immigration status. It's just the goal of that might be different. An asylee's goal is to become a citizen, I guess. And when you're in the asylum system, that's still up in the air. But when you're in the asylum system, that is a documented status in the United States, although it comes with more restrictions. Some people might not be able to work. Some, for the most part, they're not eligible for any public benefits while in the asylum process. And then refugee status is on track. Refugees are on track to become citizens. They can apply for a green card after 1 year. And then I believe you have to have a green card for 5 years, and then you can apply for citizenship. So that is the goal of the resettlement process, is that refugees will become citizens.
Rebecca, this is Sarah, one of the pharmacists. I just had a question as far as management of just like basic primary care for these patients. Are there any good resources that you're aware of that could kind of let us know about, depending on where they're coming from, like things they might be at risk for or anything like that? Or is it really just highly individualized?
Well, there is actually a great resource from the University of Minnesota. They actually have a grant from the CDC, and they're called like a Center for Excellence in Newcomer Health. And they developed an app called CareRef, where you put in, like, if you're seeing a patient from like Somalia, you can put in what country they're from, their age, their gender, and it'll give you like a readout, of just some things to look out for. So just to give you some advice on maybe things you should ask about. That has been really helpful. And the CDC also has some backgrounders on different countries of nationality that would give you an idea of where people are coming from and what to look out for. And then we do have those clinics that offer the refugee health assessment. They, for the most part, offer primary care as well, and they are really like the experts on refugee health care.
Okay, thank you so much.
All right. If there are no other questions, thank you everyone for listening in today.